Now, I would like to introduce our speaker. Dr. Susan Love has dedicated her professional life to the eradication of breast cancer. As Chief Visionary Officer of Dr. Susan Love Research Foundation, she oversees an innovative research program centered on breast cancer cause and prevention. She is also a clinical professor of surgery at UCLA David Geffen School of Medicine. One of the founders of the National Breast Cancer Coalition, Dr. Love is well known as a trusted guide to women worldwide through the Foundation Inpatient Science Education Program and her books, including Dr. Susan Love Breast books, now available in Spanish. The Foundation's recent groundbreaking initiatives include the Army of Women, developed to partner women and scientists to move research forward, and the Health of Women study, a study aimed at identifying the cause of breast cancer. Dr. Susan Love?
Yes, happy to be here.
We can start it, yes. Okay, you can start, Dr. Susan Love.
Okay. I'm very happy to be here. I would rather be with you at SHARE because it's much more fun to actually see who you're talking to. But we're happy to share breast cancer in women of color, African American, Hispanic, Asian American, and why it's not just a simple solution, and why we're hoping by getting more people involved in research, not just clinical trials, but research to figure it out, we can actually make some progress. Breast cancer is a human disease, and in fact, human breasts are unique. We're the only ones that have them when we don't need them. When you think about it, all other mammals are flat-chested, and then they develop breasts when they're ready to breastfeed, and then they go flat again. So we get our breasts, they're there. They don't show up till puberty. You've got the stem cells behind the nipple, and then puberty comes, and all of a sudden, breasts emerge. We don't know the anatomy of the human breast. We don't know actually how many holes there are in the nipple or where the ducts are. It's the only organ in the whole body that we don't know the anatomy of. And so we end up often cutting them off because we don't know what better to do. We don't really know the physiology of the breast. Are the ducts unique, or is each duct unique, or is all the ducts making the same stuff? What's the microbiome of the breast? Does it have bacteria and viruses? When they did the Human Microbiome Project, they didn't do the breast. And what happens with menopause when it retires? So there's very little we know, and part of the problem is that a lot of the research is done on rats and mice. They have one duct per teat. They're easy to study. They're easy to control, but actually you have to humanize them in order to study them. So at the Dr. Susan Love Research Foundation, we believe that we really need to have more humans being involved in the research and more research on humans, or so we can figure it out. We're trying to accelerate the eradication of breast cancer, bring better care to all women and men, and improve the lives of women and men living with breast cancer. Now, in terms of women of color and breast cancer, Fumio Lapade in 2015 called it the perfect storm. And I think that is indeed a good answer. There are differences in tumor biology and genomics in both Hispanic and African American and Asian women, plus differences in the patterns of care, and it equals a breast cancer mortality gap, particularly in African American women, but also, excuse me, in other groups. And until we study all of the aspects that are involved and have enough research that actually looks at women of color and Hispanic women and Asian American women, we're not going to understand breast cancer. If you look at the charts, the recent charts for incidence rates, so incidence is how many people are getting breast cancer, you will see that there's a difference. This is white. all races is the black line, and red is the African American line. So the number of people who are getting it is the same, with African American women and white women being higher, in fact, than Asian Pacific and Hispanic women, which is this purple line. If you go look at the death rates from breast cancer, however, you notice that the red line, the death rate is much higher in the African American group, that the white, which is the yellow line, and everybody is lower, and that down here you see, interestingly, the Hispanic and the Asian women actually have a lower death rate in the United States, at least up to 2013. So that's a very interesting chart, because it suggests that there's more differences than just access to care. And indeed, if you look here again, you'll see the African American death rate here is much higher than the white, and then again, you see all the other groups lower. And here again, you see here's the incidence, which means the numbers of cases higher, but the death rate is highest in the non-Hispanic African American black group. And Hispanic women actually are about the same as the Asian Pacific and the American Indian. So there's got to be something going on here that we haven't fully figured out. This is another chart showing a similar thing. All the death rates are going down, so this is a standardized rate, but the curves stay the same. So even when death rates go down, or with white women, they go down with African American women too, but there's still more African American women dying of breast cancer. So why is the big question? And the answer is that we don't know totally, and it's complicated. If you look at this chart, you can see that at every age group, there's a higher death rate in the African American than in the Caucasian group, and it could be, access to screening mammography. It could be access to care. But it's probably more complicated than that, because in some of these other non-white upper income groups, you also have problems with access to care, and yet the death rate isn't so much higher. So this is really it's complicated slide. It's access to care, it's culture and economic barriers, delays in diagnosis and treatment, low rates of genetic testing, lack of access to higher level testing like MRI screening. Also, you have comorbid disease, which means other things going on, obesity, diabetes, hypertension. You have reproductive factors. Early childbearing is actually protective. Higher rates of diabetes with pregnancy, and lower rates of breastfeeding. Breastfeeding is actually protective as well. You have unsafe neighborhoods without good quality food and with a lot of carcinogens and other socioeconomic factors. So it's not just one thing that comes together, but it's a much more complicated thing. And I think we sometimes like to just blame, oh, you don't get enough screening, or oh, if you just go, it's your fault, and if you just got early detection or did breast self-exam, everything would be okay. And it's not that simple. It's a more advanced stage of diagnosis, and there's a lot of biological changes as well. So it's complicated. And this is really to show you how complicated it is. It's really not just a factor of the cancer cells themselves, or the cells that become cancer, but it's the neighborhood. And the neighborhood is everything from your DNA, which is here, where there could be underlying mutations. There's extra mutations from maybe heavy metals and other carcinogens in the environment. There's other changes in disparity to access and other comorbid diseases. There's lack of safe neighborhoods. There's low vitamin D. All of these together are one factor. You've got the cancer cells here, or the cells that are going to become cancer here, and those cells are actually, and here's the cancer cells, those cells are actually dependent not just on them being abnormal. So you could have a gene for abnormal cells, but that's not going to by itself do it. You need to have all the cells around it really causing it. It's sort of like, you could have a bad neighborhood and you have a gang in the neighborhood that's causing a lot of trouble. And you could get rid of the gang, but if you don't change the neighborhood, a new gang will rise up. You can also do it the other way. You could have a bad neighborhood, but if you don't have the cells, you're not going to get it. So you need the combination of both in order to get it. And it's really all of these together locally, and then all of these things in the body that end up leading you to cancer, not just one thing. Now, what about screening? Well, what if we just, okay, that's, finding it is hard, but what if we just were able to find all cancers early, which is certainly what we were taught when I was starting out. And if you look here at mammography in the last 2 years, you'll see that, in fact, it's pretty much the same. That non-Hispanic white women, 69%, actually the non-Hispanic black have 70%, and the Latinas, if anything, are a little lower, as are the American Indians, and the Asian Americans are 69%. So it's not an absence of screening. It's not, and it's because it's not so simple that you can just find, just like, it's like the TSA. In some ways, mammography is like the TSA looking for, we're just going to find that one terrorist. But it's not so easy as that, because there's a lot of other ways to get there. And if you look at the survival rates, you can see they are improving across, and that probably has to do with this better early detection in everybody, including the African Americans. So it's not that that we're not doing enough mammography. We did that, but we're still seeing higher death rates. So it's more complicated than that. Now, if we look in Los Angeles County at the people that are at the cases diagnosed at an early age, at early stage, sorry, the non-Hispanic whites are the best, needless to say. The African Americans, though, aren't bad at 64.9%. The Hispanic 65%, and the Pacific Islanders 69%. So again, screening is not the problem. The problem is probably much more likely things like access to care. You could find out that you have cancer, but if you don't have insurance, that's not going to help you. If you have inadequate health care, then that's not going to help you. And then there's another question. Well, what about hereditary? Could it be hereditary? No, and then in the Northern California Breast Cancer Registry, they showed that BRCA, the breast cancer gene, where you have a mutation that you carry and got from your parents, is 16.7% in the African American cases diagnosed under 35, and it's actually less in the non-Hispanic Jewish whites. So we think about BRCA as being mostly a Jewish gene, but in actual fact, not true. It's also an African American gene, and in a study where African American women with a family history of breast or ovarian cancer, they were 1/5 as often likely to get testing for BRCA. That somehow the medical profession doesn't realize that there's hereditary breast cancer in the African American community. The Hispanic women of Mexican descent have been found to carry hereditary mutations, and in fact, there's a founder mutation that goes back to the Aztecs. They've traced back in the people of Mexican descent, and then some people from Mexican descent have the Jewish mutations because during the Inquisition, a lot of people left and came to Mexico. So there's a lot more hereditary breast cancer than we've been led to believe in the past. And I have to say, when we talk about Latina or Hispanic, we really have to acknowledge that in terms of genetics, it covers really a lot of ethnic and racial groups. If you talk about Mexico, you're dealing with one group, but then then Central America may have some overlap, but Puerto Rico, Brazil, Belize, you're talking Dominican Republic, you're talking about a completely other group. So when they looked at Latino or Hispanic mutation status, they found that it was complicated, and that the carriers tended to be more from Mexico, Guatemala, and Spain, but they haven't really been looked at as much in some of the other groups. So I think we have to think more broadly when we're thinking and continue research on the whole spectrum of Latin American women. Now, could there be an African mutation? We did say there's more BRCA, and that some of that is the Jewish mutation, but also there's some interesting data that shows that triple-negative breast cancer, which is most common in people of who carry the BRCA gene, is the most common when you look at Africa. In here, let me. This is the Ghana. This is American, African American, and you see the higher rates of triple negative. In Western Africa, compared to the British are the lighter one. Whoops, sorry, the British are this lighter gray, and the darker gray are the Nigerians. So higher rates of triple negative than you would expect generally. And it has been shown that a lot of this tracks back to Africa, where the slave trade started. So in Ghana and down here in Angola, you can see some of the similars. And if you look here, you'll see Ghana triple negative, 58%, 46%, 43%. Nigeria and Senegal only 27%, and some of these other African countries less so. So Western Africa, where the slave trade came from, is the source of a lot of genetic breast cancer, and that's something we haven't really paid very much attention to. In terms of quality of care and delivery of care, this is similar in African American and Latina and other places where there's not enough access to care. The mammography process is kind of broken. We said they were getting mammograms, and they are, but then we've done so great with screening, but then the delay rate for being treated, if they find something on your mammogram, is higher. And then once you get care, the chance that you're getting care that is consistent with the standard of care and the guidelines is lower. So you're not going to get you maybe have your cancer detected, but it doesn't mean you're going to that the care is completely adequate after that. You're undertreated, much less likely to be part of clinical trials. And then there are other factors, comorbidity, that can make the outcome a little worse, like obesity, that is more common in African American and Hispanic women. So the quality of care, we got better at the beginning when we thought everything was going to be early detection, and if we could just find it, we'd be great. But now what we're finding is that's just the beginning, and we really need to make the quality of care work all the way through. So what are solutions? Well, there are a lot of solutions that include better education, physician communication, navigation, systems changes. We need interventions that really are aimed at the whole healthcare system. We can't leave the responsibility of change to the patients. That's just not fair, and we've done it too long, and we really have to do it from the top down. And the majority of interventions don't really involve everybody. It's getting the word out about early detection, but not involving providers, healthcare institutions, and the policymakers, and everybody, so we really can get meaningful change. So in order to reduce the disparities, we really have to have culturally tailored things that meet people's needs. We need to employ multidisciplinary teams of providers, and we need to find the leverage points that may make a difference. Now, are there other factors? That's all well and good, but what about biology? What about subtypes as well? So if we look at the subtypes for breast cancer, there actually are different kinds. So it's not just one flavor. There are actually at least 4 flavors. There's the hormone-positive breast cancers, there's the HER2-positive breast cancers, and then there's the triple-negative breast cancers, which is always a bad name because it sounds like it's triply bad, and it just means the 3 markers are negative. It actually says nothing about the person who gets it or the cancer itself. And the interesting thing is, if you look on this chart here, you'll see that people who, when I point, it gets a little excited. The basal cells, which are the triple negatives, have the worst prognosis because that's the lowest line. And the luminal A's and luminal B's do much better, and the HER2s also have it somewhere in between. And if you look at the subtypes and ages, you find that, in fact, you get the luminal A's here in the young women, but you also get more of these, you get some more basal cancers as well, basal-like cancers. And if you look here at the basal-like cancers, you can see you see them in the 20s, you see them in the 40s, and then the peak, everybody peaks around here. So the luminal A's have 2 peaks, and the basals, which are the triple negatives, also are more common in the younger women. You can see the 2 peaks here as well. Triple negative or basal breast cancer is more likely to be hereditary, so we go back to the fact that we think there might be there may be some hereditary genes that we've not been detecting. They're more common in African American women, even though there's not as much of the usual BRCA mutations that we look for in those women. And even if you look at this is the African American, and these are the white ER positive versus ER negative. You see that you see more cases for the ER negative patients. You see more African American cases with the progression-free than you do with the risk scores. Then you on the genetics than you see in the Caucasian women. And then are there others? So we got through some factors, but there's still more factors that are involved. What about the bigger neighborhood? So not just the neighborhood in the breast, but what about the neighborhood in the body as well? And in fact, there are things that can increase or decrease breast cancer physically in the breast. Stress and inflammation, acute inflammation causes a lot of different changes on a molecular basis that make tumor rejection more likely, whereas chronic inflammation causes tumor promotion. So if you have stress, you have chronic inflammation, you have chronic health problems, you're more likely to see cancers than if you don't. Breastfeeding also, as we'll talk about, and obesity are also the general neighborhood of the body and of the breast that can change the outcome. If you look at breastfeeding by ethnicity, the people who breastfeed the least are the African Americans down here. The people who breastfeed the most, interestingly, I was surprised, are the Asian women, and the Hispanic and Caucasian women are about the same. And why does that matter? Well, we know that people who breastfeed, and particularly if they breastfeed long enough, 6 to 9 months, will have a decrease in breast cancer. Why? Well, we really don't know it entirely, but if you think about it, your breasts are there. The main purpose of them are to nourish the young. You've got these ducts. They're sitting there at the ready every month. When you have a period, will this be the month? Will this be the month? Nope. And then you get pregnant and they turn into a milk factory where they can turn blood into milk, which is pretty magical when you think about it. And that milk changes over the course of the baby. We have some recent research at the foundation that looks like all your ducts don't make milk. In the beginning, it's the lower outer, and you slowly pull more ducts in. And it's not until you've been breastfeeding almost 9 months that you're using all your ducts. And then at the end of making all this milk, you stop, massive cleanup. All the ducts are wiped out, massive involution. You get rid of them, and you make new ducts for the next kid. Now, do you make them in the same pattern as the old ones? We don't know. Or do you have extra stem cells behind the nipple to make new ones? We don't know. But theoretically, if you wipe them out, you could wipe out all the mutations that you've gotten through those years and start anew. So breastfeeding may give you a clean slate, which might help be one of the ways that it helps prevent breast cancer. In addition, though, at the time that you wipe them all out, you actually, which is called involution, you actually have a more inflammatory local environment. And so at that time, right after breastfeeding, is the highest risk for breast cancer. And when you get it, you get worse breast cancers, which is really interesting. But then, having breastfed, you have less. Now, if you take NSAIDs during that time, which you might because it hurts, you can reduce that increased risk. But another thing that we haven't really studied very much. So the time right at ending breast cancer is actually the most dangerous, and in terms of developing breast cancer. If you look at, and you could put this chart for among African American women, is the one I found, but we could do it with Latina women. We could, I guess the Asian American women are doing pretty well from the previous charts. It's complicated to enhance breastfeeding. You have to change the individual. You have to it's an interpersonal change. You need community support. You need a bigger system where wherever you're working, you have support to breastfeed. So it's not so easy, and it's not, you can't just say, oh, you should go breastfeed more. We really have to have all the systems working in order to make that kind of change. But that kind of change may make a big difference in the outcome. So it just shows you how, such as treatment, it's at all levels that the changes have to happen. And then there's the issue of obesity and breast cancer. And we know that people who are obese, because increased fatness changes a lot of the factors which tend to increase breast cancer, increase inflammation, and make breast cancer grow. It also makes it harder to detect. It might make the chemotherapy harder, the surgery harder. So if you look at that, African American women are the highest, then Hispanic, and then white, and last Asian. Now, that's interesting because I don't know if you remember now all the way to the beginning, but the Hispanic women's breast cancer outcomes were sort of similar to the Asians. And so why do they get away with being heavier and not the African American women? And we don't know. Another part of research that we haven't had enough people and a diverse enough population in the research to be able to answer some of these questions. But obviously, it's more complicated than just blaming it on things like obesity. So overall, it's complicated. You have tumor characteristics, you have the stage that it's diagnosed, and whether it's early detection and early detection works only for some kinds. You have the treatment, you have the BMI, obesity, you have your insurance type, you have all the other things, diseases you might be having, and if you combine them all, you see that all of these things come together. And it really points at why we need to have more people of color, more women of color, more African American women, more Hispanic women, because if we're going to figure this out, we're really going to have to figure it out by having everybody be part of the research. Now, one of the things that we found when I started in all of this was that the only way researchers are going to do the research on all these populations is if they're easy to find. If they have to go hunting, if they have to beg you, if they have to look hard, then they'll go back to rats, I can guarantee. So we really have to all be willing to be part of the studies if we're going to get the answers. So when we go back to my perfect storm, we've got the problems of the patterns of care and the underuse of treatment. We have the problem, the complications where you have the long time for follow-up. We have inadequate insurance company coverage, patient navigation. These things could help. These physician communication and teaching physicians could help. Patient communicating, community education interventions that are owned by the community, that the community figures out instead of the top-down. Collaboration with community health centers and academic institutions by the community, by the Hispanic women, by the African American women. So it's not totally top-down and what other people sitting in their office think is going to work, but what really will work in the community and hands-on. Likewise, we need to study the biology and the tumor genomics, which are part of the problem. The high rates of BRCA. We need to be testing more African American women. We need to be in the same way that we have a high rate of testing for Jewish women of Jewish descent. We need to figure out what the genes are. There are Hispanic genes. There's the as well, and we haven't studied the Hispanic population very much. We know there's a Mexican gene, as I mentioned earlier, but we really haven't studied a lot of the Hispanic population that we see in the East Coast of the United States to see what the mutations are. And sometimes you don't know your ancestry as well as you think you do. There was this great story about a Native American who had actually had the Jewish mutation, and she went home to her reservation and said, "How could this be? How could I have the Jewish mutation?" to her grandmother, and her grandmother said, "Well, there was this peddler." So we think we know our genetics, but we may not really know our genetics as well as we think. We need to make the clinical trials better, both so that they're accessible geographically, financially. We need to get community oncologists involved. We need to get people of the communities that we want to involve in the research participating in designing the trials. And we need precision medicine for everybody, because as we said, there may be particular genetic things that we haven't even thought of, like that interesting study showing that the genes come from the Western Africa. Nobody had ever really, once somebody tells you, you're like, oh yeah, duh. But before somebody tells you, didn't occur to anybody that we would see those same mutations. So we need all of this if we're going to really make a difference. Now, how can we sort all this out? Well, part of it is we've got to stop studying rats, and particularly white rats. Even we study too many white women, and we also study too many white rats. And we need to move from rats to people. We need to study all women and men of all ethnicities if we're going to really figure out breast cancer. And the only way to do that is if all of us are willing to participate in the research, because otherwise it's going to be whoever the researcher can find easily, and if they can't find all of the ethnic diversity of our country easily and recruit them easily, they're not going to do it, because they've got to get their grant done and they got to write their paper, and so it's really going to be up to us to do that. And we need to study all stages of breast cancer, from in situ to metastatic disease, if we're really going to understand it. And so that's why we want to encourage you to sign up for the Army of Women. The Army of Women was started now 10 years ago, when I was so mad that we were doing so much research on rats and mice. And I said to researchers, why aren't you doing this on women? And they said, well, we don't know where to find women. And I said, well, I do. And so we launched the Army of Women, and we have over 381,000 women, but our ethnic diversity is terrible. We have 86% Caucasian. We only have 3.5% African American, 3.36 Latinas. Now, we need to get everybody represented, or we're really not going to be able to have the research represent everybody. Now, how does it work? What is it? Well, it sounds fancy, but it's really a big mailing list, email list. So you sign up, and we don't take any information. And then researchers come to us with their studies. We vet them. We make sure they're okay. And then we e-blast them out to everybody. We don't try to match, because we want you to know all the research is happening. And you might not fit, but your cousin might be perfect, or your best friend. I mean, we had found this out. We had one study for Vietnamese women, and I thought, we don't have that many Vietnamese women in the Army, but we had it recruited in a day, because we had the right Vietnamese woman, and she knew everybody. So you sign up to get the emails, you hear about the current studies, there's webinars, you can hear about the research, and you hear about the study you were involved in. They're required to give you back the data, and you get to see how you've changed it. So we need you to commit to love. We need everybody in SHARE to commit to love, so that we can help answer the questions. All of these questions. I mean, I told you more questions than I told you answers today. And that's because we haven't studied women of color, Hispanic women, Asian American women enough to have the answers. And we really need to do that. So the time has come for you to change it. And if it's not you, who? And if it's not now, when? Thank you.
Okay. Now let's start the questions and answer. You still can submit questions through the question panel in the control panel on your screen. Please keep in mind that not all questions submitted will be asked due to their clinical nature. If you submitted a question and do not hear it, please feel free to call the shared helpline, and a trained survivor will be able to help. So we have a few questions, Dr. Love. Minorities are underrepresented in breast cancer research. Why is that, and what can be done to increase those numbers?
Well, I think it's a combination of things. I think one of them is we don't have as many minorities represented in the research force, in the people doing research, and you tend to, the scientists tend to do research on the people, what they know about, which is their own ethnic group. So that's part of it. But I also think part of it is they don't know how to do it. They don't know how to find them. They don't know. It's interesting that, the study that figured out the BRCA genes in the African American population was by Fumiola Pade, who's African. So it occurred to her. The studies, some of the studies in Hispanic tend to be by researchers who are also Latin American. And so we need to encourage a more diverse research population, as well as make it easy for all researchers to find women of color so they can diversify their population when they're doing the research. I mean, it's easy to study one thing and say, we're going to control all these things, and if we have more than one ethnic group, it'll be more complicated. And if you want to write a grant and you want to write papers, it's not as easy. But we have to encourage this, and we have to push it. And the more we can do it on our side, the more it's likely to happen.
Okay. What are breast cancer researchers or other researchers doing to build the trust of minority populations?
I think that also has been difficult, because especially if the researchers are not in a minority group themselves, they tend to have their own prejudices and misconceptions about how they think the people are, and they often approach in ways that don't build trust at all. That's why, in some ways, I think the Army of Women is a good middle place, or where we can get people who are willing to be in research, and then we can also help the researchers and help them with their studies. They have to submit their studies to us first, and if they're really doing things that look crazy to us and don't pass through our scientific advisory committee, which includes advocates, and a diverse set of advocates, then they're not going to recruit. And so we try to help them and educate them as well. But I think by and large, there's been a disconnect, and I hate to think that it's up to the advocacy groups to educate the researchers, but it probably is.
What can be done to make clinical trials and breast cancer research more accessible to a community of color?
I think that part of it is having people know about the studies, because they tend not to know about it, and that's where I think the Army of Women is useful, because you don't need to be very high tech. You're getting emails. Most people now have a cell phone, and so you will find out what's available, and so that will make and what studies are being done. You can go on the website and see what studies are currently being done, who's recruiting and where, and so so that's one way. Now that puts the onus on the participants looking for studies to be in, but I think in some ways we all have to take that responsibility, because they're not going to do research if they can't find people to research. They're not going to, they're going to research the people that are easy for them to find. So we have to be easy to find and help them, or we're not going to get it. And I hate to have it all fall back on women and advocates, but unfortunately, I think that's part of the problem.
Okay. What should women do if they want to be part of a breast cancer research?
Well, I think there's a number of ways to do it. So you can sign up for the Army of Women. You'll hear about studies that you can participate in. That's one way. You can go to clinical trials, breastcancerclinicaltrials.org, and you can see studies, clinical trials going on in terms of breast cancer. And that's another way. And then you can, depending on where you are, you can get trained in Project LEAD, which is a National Breast Cancer Coalition program, or one of the other. I think Komen has a program as well, a little in the science, and you can serve as an advocate, or you can help to review grants at the Department of Defense and in other venues, and help direct research that way. So there's everything from helping, sort out what research gets funded on the one side, to looking over a menu and seeing if there's studies that you can participate in, and helping to fill the research on the other side. And I think advising researchers and serving as advocates to researchers is probably one of the biggest roles, because once they really start working with people who are advocates who have had breast cancer or come from the communities they want to study, their studies become much better, and their research becomes much better, and then you also get to know what the results are, and you can help disseminate the results.
Is there any funding interest in including more community of color? Is that a challenge that researchers are facing?
To a certain degree, in some grants, I know certainly we have an NIH grant for some research we're doing in Mexico, and but you have to say, exactly the ethnic breakdown of the population that you're researching. So there is, for some clinical studies, there is some demand for that. It still bothers me, though, that the rats are white. We don't have any diversity much in the rats that are being studied in the first place. And I'm not saying that white rats and white people are the same, because obviously there's lots of differences. But I'm just saying that from the beginning, they want to, when you do research, you like to control everything. So you want to control all the factors except for the one factor that you're studying. And so the more diverse the population is you're studying, the less control you have. And that's one of the issues as well. But it just means we've got to figure out different ways of doing it.
Okay. Is there a problem with oncologists educating their patients about breast cancer research?
Absolutely. I think there is a problem with oncologists in educating patients about research in general, all patients, and certainly women of color. There are a lot of clinical trials testing new drugs, and there are studies that women that women and men can participate in. But if you don't know about them, then you won't know. And very often, it's easier for the doctor just to treat you in their usual way than to have you be part of a research study. In addition, they may be afraid that they'll lose you. If they're a community doctor and there's a good research study going on at the academic center, they're afraid you'll get lost to them, and they'll lose you as a patient. So I think there are a lot of factors. In oncology, there is more of a tendency to do clinical trials in a lot of other areas of medicine, certainly. But even with that, I do think that doctors are busy. It means an extra conversation. It takes more time. They're not being paid for that, and so it's less likely to happen. We don't have a culture in the pediatric world. They have a culture with their cancers, because they're not as common, and they're so scary to have a kid with cancer, that every kid gets into a clinical trial. So we really have learned a lot, but we don't have that culture for grown-ups.
Okay. Have any breast cancer medications or treatments been found to affect minority patients differently than white patients?
I don't. I don't know the answer to that. I haven't seen any data on it. It would not surprise me if there weren't some differences. Just as we showed, as I was showing in the slides, it's complicated. There are so many factors, if the genes are you're doing two things when you're treating cancer. You want to kill the cancer cells, so those drugs are just poison. And you just want to poison all the cells that are dividing, and that probably doesn't matter what body they're in. You're just killing them. It's like killing terrorists. Okay, on the other side, though, the neighborhood makes a big difference. The neighborhood in terms of hormonal changes and changing the hormonal milieu, the pre-postmenopausal, the other factors from the metabolism, from being, heavier versus not as heavy might change that. Doses even apart from ethnicity, might change the doses. So I think, and then, and the cancer, most of the treatments are based on killing the cells. The ones that are not, I don't think have really been studied enough in different groups. So even the immune therapies, so we tend to, again, first test them on our white rats, and then if that works, then we move to the clinical trials. But if the clinical trials are not diverse, we're never going to know if they don't work, if they work in some people, not others.
Okay. I would like to thank Dr. Susan Love for an informative program, and thank you to everyone who participated and submitted questions. Please take a moment to fill out the survey at the end of the webinar. It may take a minute for the survey to download. Goodbye.
Thank you.